The content presented on the Alpha NP podcast is for informational, educational, and entertainment purposes only. Nothing discussed on this podcast should be interpreted as medical advice or treatment. The views and opinions expressed are those of the hosts and guests and are not intended to replace professional medical guidance. Always consult with a qualified healthcare provider before making any medical decisions. This podcast may include discussions around health, fitness, hormone optimization, medications, supplements, and performance-related topics. These discussions are general in nature and are not recommendations for any specific individual. Any stories, examples, or scenarios discussed on this podcast are purely fictional, created for entertainment purposes only. They are not intended to represent any real person, patient, or actual event. By listening to this podcast, you agree that the Alpha NP podcast and its hosts are not liable for any direct or indirect consequences resulting from the use or misuse of the information shared. Welcome back to the Alpha NP podcast. This is episode 2. I'm your host, Brandon Gonzalez, and today we're going to be discussing GLPs and kind of answering some questions, concerns, a little bit of my protocols, and how I navigate the area of prescription grade GLPs with my patients. So the first question is, what are GLPs? I think this is an important point to address because a lot of times, whether it's patients or athletes or whoever it may be, they don't even really understand what it is they're taking. Some people they're calling them peptides, medications, GLPs, whatever you really want to refer to it as, but it's a little bit of both. For example, we'll kind of just dive right into it. The three main ones that we're seeing, whether it's on social media or whether it's at your doctor's office, is going to be semaglutide and tirzepatide. Depending on where you go, also now retatrutide. What these medications are is, and they absolutely are medications. That's very important to understand. These are prescription grade medications, regardless what you're seeing or hearing on the internet. They are also peptides, which is pretty unique in itself. So, something we need to understand about this is they are not just weight loss drugs. These medications are not just a magic shot that the patient takes and they lose weight, when in reality they kind of do that. It's the outcome of what happens with a lot of times, but there's so much more to it, and that's where a bit of the problem is. So to focus back on, what are GLPs? What are they? So these peptides are working in a couple ways. I like to really break it down into 3 main points when I talk to my patients. 1, blood sugar regulation and insulin sensitivity. So first, we know semaglutide, or Ozempic, FDA approved for diabetes, came out because Ozempic was being used to manage blood sugar, help patients reduce their A1C, and that type of deal. Well, when this was all going on, they realized, holy cow, everybody on this medication in the trial has dropped like 20 pounds. What's going on here? That is then what spiraled to the second FDA approval for obesity, and then that spiraled to cardiovascular disease, and so on. And eventually it moved on to the more improved medication, tirzepatide, also known as Mounjaro and Zepbound. That's very important because that can cause a lot of confusion in itself, is the names with these things. So I'm going to kind of break this down. We know that GLPs are originally diabetes medications to help better manage blood sugar and insulin. Now, with that, we have semaglutide. So let's think here. We have semaglutide, and that is the generic name, but it also goes by the brand name of Ozempic and Wegovy. Ozempic is the FDA version for diabetes. Wegovy is the FDA-approved version for weight loss. And then there's semaglutide, which is what majority of people use because of cost effectiveness, the compounded version, of course. Now we're going to dive to, actually one point I do want to make. With semaglutide, that targets one receptor. Very important. So the semaglutide targets, like I was saying, one receptor. Then we move on to, and that's the GLP receptor. Then we're going to move on over to tirzepatide, predominantly known as Mounjaro and Zepbound. Mounjaro, again, is think of this in terms of this, the FDA-approved version for diabetes. Then there's Zepbound, the FDA-approved version for obesity and weight loss. And then there is tirzepatide, which is the same as both of them, just the generic name, which is the compounded version that's used for weight loss. That's what I prescribe. I do not mess with the brand names. It is simply not affordable for patients. It's ridiculous. And then the third, which is retatrutide, and that's going to target 3 receptors. So semaglutide's targeting the GLP receptor, tirzepatide's targeting the GIP and the GLP receptor, and now we have, the big bad, strong, biggest guns in the box is retatrutide, which does not even have brand names out yet. It's finished its phase 3 clinical trial with Eli Lilly, but there's not a brand name. It has not actually come to market. There is no FDA approval. So typically when we see this, it's only being given a couple of ways, whether it's patients sourcing this stuff off the black market for themselves, research use retatrutide, or they're going to a handful of compounding pharmacies that are already compounding retatrutide. Now, with that being said, there is a third receptor there that is being targeted with retatrutide. This is very important, and that is the glucagon receptor. This is a really good medication. I think that we're going to see retatrutide in the next year probably phase out semaglutide. Maybe not tirzepatide, because there are patients that I prefer tirzepatide for. But I will say semaglutide, I think, will become obsolete probably in the next year or so, as these GLPs just keep getting stronger and more effective. The nice thing, though, that I will say about semaglutide is with all of this advancements taking place, we are seeing semaglutide becoming more and more affordable. The price is constantly being dropped with compounding pharmacies for my patients, which means in turn I can provide my patients with a better price. We're seeing these medications blow up everywhere, whether it's from social media or whether it's commercials. Now we're seeing the wave of, the Wegovy pill and some of these things, these brand names orals. In reality, the oral is not new. It's being promoted. I'm having a lot of patients call me and they're like, hey, the weight loss pill, can I get the Wegovy pill? It's now FDA approved for weight loss through the brand names, of course, but the oral form of semaglutide is not new at all. It's been out for a while under the name of Rybelsus. I don't like it personally. It's nowhere near as effective as the shot. I think it brings on more side effects through oral digestion, at least what I've seen clinically. Those are just my opinions. I honestly, cost-wise, it's not really that cost-effective. So yeah, we're seeing a huge boom of that Wegovy pill right now, but this is not new by any means. Do not think that this is a new method. No, the oral route has been out for a while under the brand name of Rybelsus. Some compounding pharmacies have already been pushing it, but it's just not popular because I don't think it's better. If you're going to go that route, you're much better just sticking to your compounded semaglutide that you've been doing already. Probably going to be more effective, may have less side effects, and that's just my opinion. Now, in terms of the whole boom of this, we are only going to see GLPs continue to boom. The medical weight loss industry was always controlled by pretty much phentermine, to be honest. Phentermine was the gold standard. There was nothing ever really that really stood out. There were some very weak GLPs you could kind of call, like, I think, my goodness, what were some of them? Like Trulicity, liraglutide, I believe is the name. So the Trulicity was like a once-a-week injection, just like the others, but it really didn't shift weight loss much. It wasn't popular because, let's be honest, it just really didn't work in the way that semaglutide came onto the market. And man, everybody lost with the Ozempic and semaglutide boom. I mean, people were just dropping. I mean, you saw celebrities, athletes, moms, children. I mean, we're seeing it everywhere. I mean, even pediatric patients now are using semaglutide. It's not uncommon to see 16, 17, 18-year-olds using this medication. And the more that this has become popular, the compounding pharmacies are increasing access to this medication. It's pretty much any sterile compounding pharmacy nationwide will have semaglutide to some extent. So That's something, in terms of availability, that's a big thing. So now not only is it popular, we've seen the results, it's been around now for a few years for sure. The availability is there, price is dropping, so we're experiencing, the popularity of this even more. Another big reason we're seeing is the popularity is this whole TikTok wave, this peptide boom right now, which I'm not going to dive into peptides. I really just want to keep this episode 2 focused on GLPs, the discussion of it, and making you guys more familiar with how this space works with this. But we're having right now, at least the current time I'm going on, this is being recorded April 22nd, 2026. TikTok and Instagram, they are just pumping the algorithm with peptides. So every day I'm getting 5, 6, 7 calls on, I want to start peptides. I've seen this reel, I've seen this video, this influencer's talking about this, which has even pushed GLPs even more in popularity. So we already know that there's a ton of pros with these GLPs, regardless of which one you go with, whether it's the 3 I'm always going to focus on, semaglutide, tirzepatide, or retatrutide. We know the benefits. There is absolutely weight loss. I want to say, and I could be wrong on this, but I remember when I was researching the data, semaglutide is around, I believe, a 15% total body weight loss. Tirzepatide is around 20%, and recently with retatrutide, I think it's come back at 25% of total body weight loss. Just continues to improve. Now, we know there's benefits on blood sugar regulation. We know that it's controlling people's diabetes. It's taking people out of the pre-diabetic category, moving them back to not non-pre-diabetics. Phenomenal there with insulin resistance. We're seeing it being used for all types of things, off-label fertility, PCOS. So much it's being used for inflammation in the body, reducing inflammation markers. A lot of integrative clinics are using this to help reduce inflammation off-label. We know there's a lot of pros, but now let's kind of dive into some of the cons and the negative side effects of these medications, and why you always need to be doing this through a clinic and not just self-dosing and taking this stuff. 3 of the big contraindications with myself when a patient comes to my practice is going to be any patients that have ever had a small bowel obstruction, have had parts of the small intestines resected, removed, where they're already at a increased risk of an obstruction from slower gastric emptying. Now, that's really important because a lot of times when patients come, they start these medications, and like anything else, we already know, whether it's a medication, a lot of times people are using stuff wrong. They don't want to put in the work, the time, the energy, the proper diets with anything. So when they start this medication, if they've already are at an increased risk of constipation, these medications can absolutely increase constipation. They can cause nausea, they can cause vomiting, they can cause acid reflux, a ton of GI side effects. It's not very common, the serious side effects like that, but I'd say maybe 9 out of 10 patients will experience pretty significant constipation with semaglutide where they can't tolerate it. What I viewed in my practice. Now, with that being said, there are ways to mitigate this. If you know you are already prone to constipation or nausea, maybe have some Zofran on hand. Make sure you message me. Let's talk to me about that. Let's have some Zofran called in so you can kind of mitigate some of the nausea, especially as we titrate the dose. But the big one I'm most concerned about is the constipation. I do not play with constipation. If, let's say, your regular bowel habits are, you have a bowel movement once a day or every other day, and that now doubles, and if you were going to the bathroom once a day, you go every other day. Okay, that's nothing crazy, but at least you're regular. But now, where I have the problem, and I see with a lot of patients, is they will start these medications, and then they will go, my goodness, they go to the bathroom once a day, they start it, now they're going every 3-4 days, and they don't tell me these things. And then when they do tell me, they're like, oh, I'm constipated. And I'm like, when's the last time you've, used the restroom? And they're like, oh, it's been 4 days. And I'm like, geez, you have to tell me these things because we can't start that routine. You have to stay, the biggest ways that I try to treat this is you have to stay hydrated. You have to eliminate the bad food. So if you're going to start a GLP and you are not going to modify your diet at all, you are absolutely wasting your time and your money. Because at some point when you come off this medication, you are going to simply rebound and you are going to rebound with vengeance in terms of body weight. So you have to build those habits of fruits, vegetables, lean meats, things that are going to help properly make your bowel habits more routine. You're going to do what you can to reduce constipation. Now, a lot of my patients will start a stool softener. If you are prone to constipation, having potentially getting on a routine with Miralax or some type of a stool softener as needed to help yourself maintain that is used a ton of times with my patients, but you need to do it the right way. It's not eat a bunch of shit, eat a bunch of garbage, you're dropping all this weight, but you're still constipated, but you're pounding laxatives. Like, that's not the answer. This needs to be done properly with the correct diet, the correct food, proper hydration, titrating the medication correctly so that you're not dealing with these side effects, or at least getting to the number where you're at and say, hey, Brandon, I am at 1 milligram of semaglutide. Anything past that is an absolute disaster. We know where you're going to need to be to mitigate these side effects. And another couple issues with patients that I will not prescribe them these GLPs are patients that have severe issues with their gallbladder currently, severe gallstones. They've been admitted to the ER with, gallbladder flare-ups, gallbladder attacks, or patients that have ever had pancreatitis. I just will not deal with it. It's not something I want to deal with the risk and getting the patient involved in that. Now, if you've had your gallbladder removed, that's a different story. Then I have no issue starting the patient in terms of that. But those are the side effects to look out for, and you really need to keep an eye on what is worth it and what is not. Now with the dosing. So anytime that there is a patient starts on any of these medications, I always start them on the lowest possible dose. Sometimes I won't even start them on the lowest clinical dose. I will literally cut that in half. So I've had patients that, won't even start on the 0.25 milligrams of semaglutide or the 2 milligrams of retatrutide. I'll literally cut that in half just to see where they fall, especially for sensitive patients that know they get nauseous easily, or they're already constipated, or, they have a very important high stress job. They can't afford to miss work and be home nauseous, vomiting for 2 days. So I will definitely titrate according to the patient, but we always will start on the lowest dose. Now, with me at least, I like all my patients to check in weekly. So even if if you're new on this medication, you're not bothering me. I always tell the patients, reach out to me, shoot me a text. Hey, Brandon, I did, my 5 milligrams of tirzepatide this week. This is week 2. This is going great. This is what I'm dealing with, so I can help adjust as needed. I do not want patients self-dosing, then that's a big problem on its own with the black market and this gray market with this research use nonsense. Patients are they don't even know what they're reconstituting. They're mixing up all kinds of stuff. They're taking doses that are not therapeutic. Lot of issues. So anytime there's I always advise, whether you're with me or you're at another clinic, check in until you reach a point where you've been on this medication, you're dialed in. Maybe you don't need to check in as frequently. You know what you're doing, you're stabilized, you're only checking in during your refills. That's totally fine. But you definitely got to find that sweet spot of what works. Maybe you thrive on semaglutide. Maybe you thrive on tirzepatide. Maybe you don't tolerate any and you need retatrutide. It's going to be very patient specific on this journey, as well as mitigating side effects, as well as, being cost effective. I always try to be cost effective with my patients. Some of them come to me and they're like, bam, I want retatrutide. And I'm like, look, let's slow down. Very expensive. It's the more newest one. Let's start with semaglutide. Let's see if you can tolerate it, because if you can, you're going to save a ton of money, literally, just by using semaglutide. So that's always a factor too, is, mitigation of side effects, as well as what is most cost effective for my patients. Okay, so now we're going to dive into another little part of this. Obviously, I am very biased. I always will acknowledge anytime there's a topic I'm discussing, am I for it or am I not for it, so you can see if there's a bias. I think that's very important for whether it's physicians, nurse practitioners, PAs, pharmacists, to acknowledge when they're discussing something so that patients are aware if there is a bias. I am in performance medicine. I am always pro GLPs when done correctly. Now, With that being said, we've talked a little bit about dosing. We've talked about the types of GLPs, what they do. They target different receptors, how important diet is, hydration, titrating these medications properly, as well as realistic goals. There is one little part here that I'd like to talk to, and this will be more clinical experience on the day-to-day. I see a lot of this being done wrong. And honestly, I understand that that's what, medicine was created for reasons like this. But when patients will start these GLPs, 50% of them, they don't want to change anything. They don't want to change their diet. They don't want to exercise. They don't want nothing. They just want a magic shot, that costs a lot of money and they're willing to pay for it. And listen, it's going to work. It doesn't matter what you do. These medications are so powerful, they are going to work. You could eat McDonald's and fucking Starbucks all day long and you're still going to lose weight. The way they correct insulin resistance and, the metabolic effect they have on the body, the appetite suppression, slowing down the gastric emptying to, mess with the brain's satiety and all these type of things. They're very potent. Now, with that being said, again, that doesn't mean you should use them this way. I have patients that do, and that's up to them. If they're not going to make the changes in that, hey, they just have to understand that, they're at some point, if they ever come off the medication, they are going to rebound insanely. Now, with that, the right thing to do here is, like we said, you need to eat properly. You need to make sure you're getting adequate protein, because this is another little side quest here. Very common with my female patients. They will start a GLP. Great, they drop 20 pounds in 3 months, okay? They come back to me 3 months later, and it's very notorious, and they're losing hair. And, now there's this big myth that these medications directly cause hair loss. It is not that the GLP is just targeting a receptor like a DHT receptor in the scalp, or, an androgen receptor that's causing some form of hair loss. What is really taking place here is you are basically, a lot of these patients are shocking their body. They're going from, we're just going to make up numbers here, 4,000 calories a day to 1,000, or 2,000 calories a day to 1,000. Whatever it is, they're putting their body in this massive shock. They're dropping weight rapidly, and they're not eating. So they throw their body into starvation mode, a fight or flight type of deal, and the body will induce a hair shedding phase. It's basically a panic mechanism in a sense, because what happens is you're deficient in vitamins, minerals, you're in a calorie deficit, you've dropped a ton of weight, and what will the body do? It is now just going to shed hair. What do I do for this? Whether it is, a prescription grade injectable, a medical grade oral supplement, I will always try to put my patients on, we have in-house oral supplements that I use first line, or I'll jump straight to prescription grade injectables, whether it's B complex, B12, mineral injections. There's a lot of different routes I go with this, but it's absolutely something that should be done. I tell all my patients, if you're going to be on a GLP, let's be preventative. Start a very high quality multivitamin, whether you're getting it, through your current doctor's office or you're coming to us. What I do say is stay away from Amazon. Do not purchase any supplements off Amazon. The amount of counterfeit products is ridiculous. I use orthomolecular supplements. That's who I personally use. They have to literally print on the bottle, this is not for sale on Amazon, because they are such a high-grade nutraceutical company that counterfeit products are being sold all day long. It's happening to a lot of my patients, and I'm like, hey, where did you get, your fish oil from? And they're like, oh, I saw it on your story, Orthomolecular's fish oil, and I bought it on Amazon. And I'm like, absolutely fucking not. Like, it is not on Amazon. The company does not sell on Amazon. I mean, the company has done independent testing, purchasing off Amazon, retesting it. It's completely counterfeit products. They're not even batch numbers that trace back to, one of their nurse practitioners, physicians, or PAs, that it's attached to their NPI, like their license number. It is pure counterfeit. So please be very careful where you're purchasing that from. Even though you absolutely should be on a good multivitamin when you're getting on a GLP. With that being said, though, that will kind of address the hair loss issue. Slowing down the rate of weight loss, making sure the patient is eating enough protein, making sure the patient is hydrated, making sure the patient is not dealing with vitamin D, B12, magnesium, different deficiencies, iron deficiencies that are going to lead to hair loss or hair shedding induced by a GLP indirectly. Very important. So that's a very big important part. Now, I want to touch on to another part with this. There's a lot of, images going around where they're showing, different types of scans, DEXA scans, whatever it may be, a year, 2 years apart with a patient on a GLP where they're now saying, oh my gosh, GLPs are, eating up bones. And you're seeing, these image scans of a bone that is, nice and dense. 2 years later, it has early signs of like, osteoporosis, osteopenia, things like that, where there's like, hey, what's going on here? Why are we having bone degradation and bone breakdown in these, healthy individuals? Again, this is going to come from the lack of nutrients, the inadequate amount of protein, significant weight loss, which is also resulting in skeletal muscle mass decreases. What you need to do anytime you're on a GLP is, most of the time when a patient will start a GLP with me, bam, we start the GLP, they're having great results. Early on in, if not at the start, you need to potentially look at testosterone replacement therapy, regardless, male or female, because we're seeing the term I know that goes around on social media is like the skinny fat. You lose all this weight and, people, it's like, oh man, I've dropped 30 pounds, 40 pounds. But when they're doing some of these, these I think like the InBody and some of these, metabolic scanning devices, that physically scan the body and show you percentages, yes, they've lost a lot of weight, but their skeletal muscle mass has gone to shit, which that's not the goal, because that is not healthy to drop a bunch of weight, but now you're not holding a significant amount of skeletal muscle mass for your, your ratio of height to weight and that type of deal. You absolutely need to weight train. It is non-negotiable. And, people think that weight training means you need to go get a gym membership and you need to throw on, these ridiculous routines and this type of stuff. You don't need to do that. You don't need to be a bodybuilder. Buy a set of dumbbells, buy some stuff at the house, and weight train 3 times a week, even for 20 minutes. For some of my older patients or my patients that do not want to go to the gym, do not have the time, you could do so much with literally 5-pound dumbbells, 10-pound dumbbells, and 20-pound dumbbells, and some bands at the house. But it's non-negotiable. You have to do some form of resistance training. You need to keep the protein intake adequate, and you need to make sure you're on a good multivitamin to prevent deficiencies, because there is no point there in losing. You lose a bunch of weight, but if you lose all your muscle, like, what are we doing here? That's the counterintuitive to the whole program. So with the testosterone replacement therapy, we are able to maintain that muscle mass by, increasing the anabolic ability in the body, decreasing the catabolic ability in the body. So no matter what, the patient retains muscle, builds muscle easier when we bring that. For example, a female level with Quest, 2 to 45, we're in range. Most of my females, I'm bringing to 100. I'm bringing to 200 on a total testosterone level. Like I said, this is very general, way more to talk about with that. But I'm bringing, a lot of my men Quest 250 to 1,000 or 1,100. I'm bringing most of my guys to 1,200, 1,300, where they feel best. Now, with that being said, it is important, but, I understand everybody does this differently, but best practice would be to get your hormones checked, see where you stand, add in that testosterone with the GLP, weight train, increase protein, increase your protein intake, as well as being on a very good multivitamin with a strong resistance training program. That is going to be the right way to use a GLP. Now, listen, I get it. 75% of my patients don't do that, but when you guys want to know the right answers, this is the right way to handle these situations. In the clinical studies you've seen, when they follow up, and this was originally with like Ozempic, when they follow up with these patients a year later after the trial had ended, these patients had come off the medication, majority did not have any lifestyle changes. No diet changes, no exercise changes, no big real lifestyle changes. When they followed up on this trial, almost the entire trial, this is very important, gained every single pound back with this medication. So what does that say? I love these medications. I love what it's doing for people, how it's changing a lot of my patients' lives overall, but we need to acknowledge something that it is still a medication. So if you are going to use this the wrong way, you can pretty much expect almost a full rebound of weight. Out of, the 1,000 patients I've probably prescribed this to and managed and dealt with, I would say, I'm not exaggerating here, maybe 15 have been able to maintain significant weight loss after coming off these medications. So that's very important because I always like to show the pros and cons of these things. I'm in performance medicine. This is what I do. I love it. But I'm not going to sit here and tell you that this medication is a wonder drug. It is, but when you don't use it correctly, you are probably going to gain most of the weight back. It is a medication. Another example I'll use, birth control. For girls taking birth control, it works as long as she takes the birth control. When she does not take it, it does not work. Just like most medications in the world of healthcare and medicine. Now, what was another one here I wanted to talk about? This is really important, the future of these GLPs. I definitely think that we are going to see, GLPs are going to take over. There is no stopping it. These medications are so great. They are increasing people's lifespan. They are changing people's lives that are obese, that have even had osteoarthritis. I'm sure we'll see an FDA implication coming out one day for, osteoarthritis treatments. Because you got to think, when you drop 70 pounds, no shit your knee doesn't hurt. No shit your lower back doesn't hurt. People are able to spend more time with their grandchildren, with their children. They're more mobile. Their activity levels are increasing. So, honestly, once these drugs become generic one day, I think diabetes in a whole, I think obesity is going to change drastically. I do think there's a lot of things that need to be worked out from the proper protocols with this, but man, these medications are going to change the future of medicine. I have patients that come off blood pressure medication, cholesterol medication, other diabetes medication, NSAIDs because of knee pain and back pain with massive weight reduction. It is absolutely life-changing, as you can imagine. So I'm seeing patients come off 5 different meds after they drop 50 pounds with the GLP. So my stance. I love them. I'm all for them. They're life-changing when done correctly. You always need to make sure you're using these medications correctly. So the one last thing I would like to mention before I kind of wrap this one up is going to be, when you're using a GLP and you plan to come off, typically what I will tell my patients is you're going to need to titrate down slowly. Let's say you're on 2 milligrams of semaglutide, and I keep talking about semaglutide. I love tirzepatide and retatrutide, but let's talk about semaglutide. It's easy numbers. You're on 2 milligrams. You've reached your weight goal. You've lost 40 pounds. You're happy. You're where you need to be. You've dialed in your diet, your exercise routine. I tell the patients, let's slowly start titrating you down until you hit that number. Let's say it's 1 milligram, where you go, Brandon, I'm already getting cravings back. I want to eat. I've gained a couple pounds. We can't go less than 1 milligram. I will typically find that happy medium with a dose with a patient where they are able to say, hey, I can use this dose. I'm able to come down a little bit, but this is where I need to be to maintain this weight loss, to be happy, to control my appetite, and it's cost effective because now you're using maybe 1.25 milligrams a week of semaglutide instead of 2. So that vial you're getting from us for your treatment protocol is going to last you so much longer. So I'm able to help save my patients money, reduce their medication. But to answer the question directly, most people are going to need some form of a maintenance dose, even if it's not every 7 days, like your standard shot. Maybe you could push it out to every 9 days with a little bit of a lower dose. That is going to help you maintain this for the long-term plan. Coming off the medication, blood sugars will return to where they were. Most of the time, weight will return to where it was. You are going to lose all the benefits by coming off. I try to get my patients on a titration schedule where it's cost-effective, still beneficial, and it's something realistically they can maintain for as long as needed. So that was a lot of information. I think I've touched on everything, honestly. I definitely will have another. We will do, this is episode 2, a main point on GLPs, but I will hit down the road another recap with GLPs. We'll target some more questions. Feel free to DM me questions, guys, that you want answered. I'll discuss them in depth. My experience, what I'm seeing some of my colleagues doing, where this space is headed with GLPs and what's going to come out, in another year. Who knows? We're definitely going to circle back to this topic, but I think I've hit all the most important points that I feel with these GLPs. Great medications. They are absolutely going to change the world of medicine. I know there's a lot of back and forth with the FDA and compounding pharmacies, and offices have them and don't have them. I know it's very frustrating. I do think in years to come, we are going to see this become more affordable. By how much, I don't know, but I do think we're going to continue to see little drops on these medications price-wise, which is great for the patients, great for the clinics, and the longevity in this space. I think this was a good discussion. I appreciate you guys listening. Make sure you like, follow, and subscribe. Follow me on Instagram, the Alpha NP. Feel free to DM me. I love talking to you guys. If you're a patient in my practice, I appreciate all of your support. If you're not a patient and you want to become a patient, feel free to reach out to us. We are licensed in about 10 states right now. We're constantly growing. The goal is to get about to 35 states, all the states that allow nurse practitioners to practice independently. We will be licensed in at some point. It just takes time. But we're in about 10 states right now through telehealth, obviously in person in Florida. So however we can help, we're always here. I appreciate it, guys. Stay tuned. Down the road, we are going to have some guests. I'm working on that, but there's just been a lot of topics I felt I wanted to discuss with me alone until we get to that point. But I already have some really good people you guys are going to like that we're going to have on this podcast to discuss with. So, all right. Talk to y'all soon.